All right, so we're just going to move right along. So this is actually has a lot of similar concepts with the prior talk. So we're going to talk about pitfalls in MSK radiology. So again, we talked about this a little earlier, but the most common missed fracture is the second most common reason for a lawsuit in the U.S. And again, a missed breast cancer is number one. And the missed fractures, the ones that we miss the most often, can delay patient care. They can lead to chronic disability, and they can obviously set you up for medical legal issues that you may not want. All right, so the outline of today, the rest of this talk, is to discuss the causes of diagnostic errors in MSK trauma radiographs. And we're going to discuss the most commonly missed fractures. So basically, I looked at a lot of different papers and looked at our own QA database to see what are the fractures that we miss the most. And I'll talk about some tips that we can use to try to help you diagnose those fractures so we don't miss those. All right, so typically these errors in diagnosis are a couple of things. Why would we miss them? Well, one would be that they're very hard to see, right? These are very subtle findings, or maybe you had poor quality or insufficient films that don't help you look at the study. Two would be poor medical knowledge. You just, unfortunately, maybe you don't know the anatomy, you don't know what the common fracture are, so you don't know the association between the history and the injury, so you're not sure what to look for. And other things would be like you're rushed. And I think we're all very rushed in terms of our day-to-day practice, but obviously you need to set enough time that you can actually look at all the images and make your diagnosis. Satisfaction of search can affect whether or not you make a diagnostic error. And also you may just have a poor eye for the findings. So we're really going to talk about these the top two sections, because the other ones is kind of hard to kind of teach that or tips for that. So subtle findings. So here's a case, someone has foot pain here. Does anybody see a finding here? 35-year-old woman with foot pain. Now 2 weeks later, I think everybody can see that there's a subacute or chronic fracture there that's healing. Now, if we go back to the prior study, we can see that there's very subtle periosteal reaction there along the head of that third metatarsal. Right? May not have been faulted for not seeing that, but some of these findings can be quite subtle. Now, insufficient views, this can be very important, and this can be something that you can sort of make sure that you do get enough views to be able to figure out what you need. So in this case, this was a 54-year-old man with fall in the front of the knee, and all they got were AP and lateral views. And the film was basically read as normal. But 3 days later, still persistent pain, they actually got a sunrise view now, and now you can see that vertical fracture along the patella that you don't see with the AP, and plus the AP, the knee was a little bent. You don't really get a great look at the patella. So again, you can miss findings if you don't get the right views or have sufficient views in order to make the diagnosis. Another reason would be poor anatomic knowledge. All right, so which one of these has a fracture? All right, so in this case, this is a normal growth plate, right? On this is a fracture, because the fracture line is actually transverse, whereas normal growth plate in a child is going to be sort of oblique or longitudinal along the long axis of that metatarsal. And in this case, there's actually fractures and at the side of the growth plate, right? But if you don't know the normal growth plate pattern at the base of the fifth, you may overcall that first image as a fracture. Also, knowledge of injury mechanisms can be very important. For instance, if we see this patient with ankle pain, on the AP view at the day of the injury, we show that there's some mild widening of that medial ankle mortise. Right? So, but if you just call down and said there's mild widening, and you don't realize that if you have medial ankle widening, it's usually indicative of injury to the deltoid ligament, and it's usually related to an eversion type injury of the ankle. And with eversion type injuries, the talus will hit the fibula. And if you don't see a fracture in the distal fibula, you have to suspect a fracture more proximally or higher up. In this case, we do. We see a fracture there of that fibular neck. And this is consistent with a Mason-Neuf injury. And these can be problematic, not for its structural component, but because these things can actually be very close to the perineal nerve and cause laceration if there's displacement of that fracture fragment, and it can cause foot drop. All right, so fracture misses. One thing to remember is that we're actually not that good. We miss about 30% of findings. And by this, I mean, if you take, they've done studies where basically they take studies with all abnormal. Let's say you take 100 abnormal studies, but you don't tell the radiologist they're abnormal. And you have them read through these 100 cases. They're probably going to get about 70 right. And 30 they may call us normal, right? But luckily, we have normal cases in our day-to-day practice, which it makes us look actually a lot better. And by this, I mean, if now let's say you took 100 cases and 99 are normal and only 1 is abnormal, I could get my 12-year-old daughter just call everything normal, and she would have a diagnostic accuracy of 99%, right? And so in general, we actually our miss rate is about 2 to 4%. But that's because there's a lot of normal cases in our day-to-day practice. So one thing about the fractures is the sites the fracture misses that we see the most are, we can see them in very common fractures, such as distal radius, the metatarsal, the hand, the ankle, and also uncommon sites because we were just not looking for them. Things like the sternoclavicular area, the lateral process of the talus. And also one thing is around joints. They've shown that with a lot of these musculoskeletal misses, we miss things because the fractures occur very close to the joint space, and so there's a lot of overlapping structures. All right, so now we're going to talk about some of the fractures that that we miss a lot because they're very common, or because they have because we're not suspecting it. So sternoclavicular fracture and dislocation. It's a pretty uncommon injury, but what you want to look for is asymmetry of the clavicles here, like in this case. And typically, when there's a injury there, it's a posterior dislocation because you have trauma directly to the chest and pushes the clavicular head posteriorly. The problem with this is that you have injury to the great vessels, and you can really diagnose this very nicely with the CT scan. In this case, we can see that posterior dislocation of that clavicular head on the right, and then there's compression of the brachiocephalic vein by that clavicular head, and this can cause the injury of the great vessels. Scapular fractures, also uncommon injury, but it's usually due to a major trauma. So if you see a scapular fracture, you have to be worried that there's other injuries that could be present. The best way to see a scapular fracture is going to be on the lateral view, and it can be anywhere, but a lot of times we can see it in the scapular body, and there you can see that fracture of that scapular body that's minimally displaced. And you want to check this on all your shoulder films, because it's one of the things that I don't think is on a typical checklist when you're looking for shoulder radiographs. The problem with scapular fractures, again, is that they're associated with a lot of other injuries. In this case, here's a AP view of the shoulder, but if we look here, you can see that scapular fracture, that superior margin of the scapula. And if you look at the CT, there's a bunch of other injuries, including clavicular fracture, mediastinal gas throughout the chest. So it's really not the scapular fracture that's going to be the problem, is that you want to look for associated injuries when you do see a scapular fracture. Posterior shoulder dislocation. This is something that is very, very commonly named as a problem for lawsuits. It's not that common compared to other shoulder dislocations, and it's usually due to either anterior trauma to the chest or seizures. But the major problem is that we missed 50% of posterior shoulder dislocation if you just do the radiographs. So a couple of tips to look for the posterior shoulder dislocation. One is to look for something called the positive rim sign. You usually get a widening along the medial aspect of the humeral head and the lateral glenoid. And number two is something called the light bulb sign. I find this very helpful. If you see the shoulder in internal rotation on all the images and it's locked in that, you want to be very suspicious for posterior shoulder dislocation. And so it's going to typically, you get this light bulb appearance to that humeral head. And what happens a lot of times is that technologists come in and they say, well, the patient was uncooperative, they wouldn't externally rotate their shoulder. Well, it's because they can't. They're posteriorly dislocated, and they can't actually externally rotate that shoulder. The trough sign is you get a depressed fracture along the humeral head that's outlined with the glenoid rim in between the two lines here. And again, you can see that these radiographs, the shoulder is in internal rotation. Now, if you get an X-ray view very nicely to see this, you can see that the humeral head is posteriorly displaced in relation to the anterior coracoid process. Radial head fracture, very, very common injury. We want to look for a joint effusion, and we're going to see displacement of the anterior or posterior fat pads. In adults, typically when you see the effusion, it's going to be a radial head fracture. In kids, it'll be a supracondylar fracture. You must have a true lateral, and that's usually the problem when we don't see the effusion. So one thing is, this is an example of a bad lateral view. And so what you really want to get is something like this, where you can get that medial epicondyle in profile, looks like a circle there. And then you see this little Y appearance here, where you see the fusion of the coronoid and olecranon fossa. And when you see that, then you know you have a very good lateral where you can actually evaluate for a joint effusion. And so here there's an anterior fat pad, posterior fat pad, and on the oblique view, we can see the radial head fracture. Distal radius, very common. In some studies, this is the most commonly missed fracture in MSK. And what you want to see, this in scaphoid, I think on every single wrist trauma, you want to make sure that you're not missing a distal radius or scaphoid fracture. It's often associated with ulnar styloid fracture. And one thing that I can find very helpful is something where you see dorsal tilting of the radial articular surface. This, I feel, if you can see this, you can help you determine whether or not there is or is not a fracture. So a little bit about anatomy and just a couple of quick angles here. If we look at the distal radius, normally there should be about a 12-degree tilt of that distal radius. Now, if you get a nice lateral view of the wrist, that articular surface of the radius should be tilted about 11 degrees volar, right? And so it's easy to remember because you can just double the percentages here. But just this part, it should be tilted just a little bit volar, about 11 degrees. All right, so using that, one of these images, there's a fracture, one there is not. So we look at this. That's tilted 11 degrees volar. Whereas on this one, this is tilted dorsally about 5 degrees. And that's enough for us to see the fracture. What happens with typically collie fractures is that you get buckling of that dorsal cortex and you lose that dorsal tilt. And so these fractures that are very subtle, I think a lot of times, even when you look in the lateral view and you see that abnormal tilting, that can be very, very helpful. So that's normal. And on this one, you can see it actually quite well here on the AP view here. Another example here. I don't think anybody would call a fracture here off of the AP or oblique view. But when we look at the lateral view, again, if we draw our line straight to the radius, perpendicular to that, and an articular surface, this is dorsal tilted. And so there's actually a fracture here, the distal radius. And if you don't believe me, we did an MRI, and there's that fracture of distal radius. Very subtle, but I think it's enough that you could call it on just the lateral view of the wrist. Metacarpal and phalanx fracture, also one of the more commonly missed fractures. The problem is that they're easy to see if they're within the mid portion of the shaft, but if they're next to the joint space, they're very hard to see because there's a lot of overlapping structures. Also, if somebody has arthritis, that can also be very hard to see. You always want to check the base of the metacarpals in all these hand views and look at the lateral view. So in this case, where's the fracture? Anybody see it? It's actually right there. And on the CT, you can actually see the fracture here. But the reason why this is so hard is because there's arthritis going on, there's spurs, and this is right next to the joint space. There's so many overlapping lines here. And so if you're not looking for a fracture there, it's hard to see. Now, if it's in the mid shaft, it's a lot easier to see, but always run a view through the base of the metacarpals on these hand films. How about on this case? Do a close-up here. Now everybody can see the fracture. Again, these fractures next to the joint space, they're hard to see. And also, this is not great because they did wrist films when this person really had a fracture of the distal phalanges. They should have got hand films, but that may or may not have helped in this case. Always look at the lateral view. On this AP and oblique views, we don't see anything. But on the lateral view, you can see this extensor tendon injury here. Another example here. This one, we actually don't see a fracture. But I challenge anybody to actually do that with their finger. And you have flexion of the DIP and extension of the DIP. You can't do that. The only way you can do that is if your extensor tendon is ruptured, right? And so that's very hard to do, right? You'd have to kind of hold this straight and kind of do that in order to do that. And so this person did have an extensor tendon injury. Another thing that we can see only in the lateral view is the volar plate injury. And this can be quite common. You want to look at it on the base of that middle phalange. Scaphoid fractures, very, very common. We miss about 20 to 30% of these on radiographs. You want to recommend a CT or MRI if you have persistent pain. The major issue with this is if you miss it is that it can lead to avascular necrosis. Like in this case, you have a fracture there, increased sclerosis of that proximal pole. On the MRI, you can see sclerosis within that area compatible with avascular necrosis. Here's the AP view. Don't really see a fracture, but you can do something called a scaphoid view where you only deviate the wrist, and now you can see the fracture a lot better. So if it's helpful, you want to do different views in order to take a look at the injury. It's another case here. And again, if you can't see it, MRI is always going to be your best bet when you're suspecting these fractures. All right, so that's upper extremity. We're going to go real quick with lower extremity. Proximal femur fractures, very common. Typically, we see these in osteoporotic postmenopausal females, usually due to high velocity trauma. Bad consequences if you miss this, obviously, right? Because it can lead to a lot of major issues. But it can be hard to diagnose in patients with osteoporosis. So one of the key things is something you look for offset of the trabecular lines. So if we look at a normal hip radiograph, right, there's typically the compressile and tensile trabecula, and it actually forms this relative loosened area here called Ward's triangle, right? In this case, if we outline the femoral head here, and actually you can outline this area at the side of the fracture, you can see that these lines actually don't meet up. And so when you see offset of those lines, that can be very helpful when you're looking for subtle fractures of the proximal femur. The other thing is that you usually have a nice sort of broad curved contour to the femoral head. Because a lot of times with these fractures, you get valgus alignment of that proximal femur. You can have this acute angle here along the lateral aspect of the femur. How about this case? Is there a fracture? I don't know if it's projecting that well, but you can see this little spurs here. Could that be the edge of the fracture line? But if we actually look at the trabecular markings, you can actually see them go all the way through and they're connected. And this is actually somebody with, and also there's a nice smooth contour of that superior femoral head. And so this is actually somebody with severe osteoarthritis, and this is a cap of osteophytes. And that can be very hard to tell and to identify some of these fractures. And if you get concerned, it's worth it to go ahead and get the MRI. Hip dislocation, often due to high velocity trauma, it's the knee strikes the dashboard and pushes that femur back posteriorly from the acetabulum. So the vast majority are posterior. CT can be very helpful to look for the fractures and associated injuries. One trick, now this one should be fairly obvious, but one trick is that typically the femoral head, if it's posteriorly dislocated, it's going to be a little smaller than the normal side, because this is going to be closer to the film cassette, right? So you can kind of see this relative small. And the other thing is that typically when it's dislocated posteriorly, the lesser trochanter will be seen in profile because the femur will be internally rotated. So here's on the CT, we can see that the femoral head is dislocated posteriorly, and then this internal rotation of that femur. And in this case, it's also important to point out that there's a loose body in the joint, and that can prevent relocation of the hip. Segond fractures. I kind of show this case because sometimes the findings can be very subtle and can be associated with a significant injury. And in this case, this is an avulsion of the lateral tibial plateau. It's either due to a tear of the ITB, the lateral capsule, or the oblique band of the fibular collateral ligament. The main issue with this is that 80 to 90% of Segond fractures are associated with the ACL injury, and about 60 to 75% are associated with a meniscal tear. So in this case, if you see this, you want to recommend that MRI. There it is there. And then on the another case here, you can see the Segond fracture. There's a joint effusion. Here's it on the MRI. You can see that little fleck of bone attached to the iliotibial band. And with the MRI, we can see that ACL tear. Vertical patellar fractures, we talked about this a little earlier. This is a transverse patellar fracture, which is pretty easy to see on a lateral view. But if you have a vertical fracture, they can be missed if you don't take the merchant view or the sunrise view. And so typically, we always want to make sure that even if they don't ask for AP and lateral view on their series, that we want to make sure that we get that merchant view so we don't mistake a vertical patellar fracture. Like in this case here, you can see a joint effusion, the patella looks pretty good, but on the merchant view, we can see that vertical fracture through the patella. Now, you don't want to mistake that for a bipartite patella, because you can see this in about 2% of the population. It's always almost in the superior lateral aspect of the patella, and it can be helpful to get both sides because it's a bilateral in about 50% of cases. All right, Lis Franc injury. This is also one of the more commonly causes for lawsuits, actually. And so injury of the midfoot ligaments of the bones. The metatarsal bases will be misaligned in relation to the cuboid and the cuneiform. The main issue is that there's no ligament at the base of the first and second metatarsal, and if you miss this, this can lead to severe disability in some cases. So a couple of things to look for. Step off at the medial base of the second metatarsal with the medial cuneiform, and also elevation of the metatarsal bases. The second comment, I think a lot of people don't actually look for that, but I think that can be very, very helpful. All right, so the first thing we're talking about is you want the medial aspect of the second metatarsal to be aligned with that medial aspect of the medial cuneiform. You should be able to draw that line. On this case, we can see that there's a step off there, and that's because there's a separation. The Lis Franc ligament here is torn. Kind of subtle, but this is enough for us to call it. A couple things to remember is that in normal anatomy, you have ligaments that connect all these structures here, but there's actually no ligament that goes between the first and the second. The Lis Franc ligament goes this way, and thus it's very weak. And so when you tear this ligament, all of these metatarsals will move together in one way. Another thing to be helpful is the normal foot. Remember that the base of the first articulates with the medial cuneiform, the second with the intermediate, the third with the lateral, and the fourth and fifth with the cuboid. Right? Always look for that alignment on every single foot radiographs, because sometimes you can have abnormal alignment here. So in this case, we have the first not aligned with the medial cuneiform, the second with the intermediate, that's way off, and these are actually all misaligned along here. Always run those connections between those tarsal and metatarsal joints on all the images. The other thing is this elevation of the metatarsal bases. Look on the lateral view, and you can see this elevation of the metatarsal basis in relation to the cuneiforms. And this is malalignment of that basis. All right, so using that, which one of these films is abnormal? Which one has the Lis Franc injury? All right, so we take a close-up here. You can see here, there's elevation here, very subtle. That is nice and smooth. But if we look on the corresponding AP views, there's that step off, and there is the normal alignment. So the top images are the ones with the Lis Franc injury here. A couple more cases here. Lateral process of the talus. This is something that a lot of us don't think about. It's also called a snowboarder's fracture. It's very often missed because typically we're not looking at that lateral area of the talus. We're not looking for talus fractures. A lot of times we're just looking for the medial malleolus and the distal fibula, but this can be confused with patients with sprained ankles, and they can have prone to having non-union, which can have chronic disability. So look for this on all ankle radiographs. In this case, here's the MRI. We can see that ununited fracture there. And on the CT, also ununited fracture with the sclerotic margins. All right, so this is the most commonly missed fracture on most studies. And this is basically a metatarsal fracture. So we look here. It's very subtle. But again, fractures near the bases or near the joint space can be kind of hard to see. And so there it is there, and we can see at the corresponding MRI that there's some marrow edema there. Now, if you see a fracture typically in the mid portion, that's pretty easy to see. Again, it's those fractures in the metacarpals and the metatarsals near the joint that are going to be the most hard to see. And so typically, if there's pain, I don't see a fracture there, I'll just recommend VP films in 7 days, or if they get an MR if they're very, very concerned. All right, so a couple of tips. What did we learn from some of these cases? One is to get good quality films and sufficient views in order to figure out what you need to see. If you don't have them, at least comment on that in the report and recommend additional or repeat imaging. Read the history. It's always so important there. If they ask if there's a patellar fracture in the history, actually look for a patellar fracture. And if you can't get that from the views you have, you may need to get additional views. Know the anatomy, especially growth plates in kids. Use reference books if you're unsure. Look at all views of the study, right? A lot of times, especially certain findings are only seen on one view, such as a lot of the injuries along the hand on the lateral view. Look especially hard around the joint spaces. Again, some of the most missed fractures are the metacarpals and the metatarsals in the foot and hands, but proximally at the joint space. And then look at comparisons, and again, look at the films before you read the report. That way, you won't have any misfindings or be biased to what the report says. So, in summary, fractures are commonly missed, and this can lead to chronic disability and delayed treatment. It's important to acquire really good quality films and the appropriate films. You need to know the relevant anatomy for the trauma mechanisms. Remember that the most commonly missed fractures are those in the distal radius, small bones of the foot and hand. And there's a couple of injuries that you don't want to miss because they can have some high consequences. Ones that we talked about with the sternoclavicular joint, the posterior shoulder dislocation, scaphoid femoral neck, and the lateral process of the talus. Practice good radiology habits. Read the history. Look at the films. Look at all the films, including the lateral view on the hand. Get additional views if you need it. Look at the old films. Check for the blind spots where there's overlapping structures. And use some of the diagnostic tips that we talked about for how to not miss some of these common fractures. And don't worry, there's a lot of good lawyers out there. All right, so real quick, again, for time, we'll just kind of go through these pretty quickly. A posterior shoulder dislocation, the humeral head is locked in. External rotation, internal rotation, it's not locked, none of the above. All right, so hopefully all can recognize that the shoulder is internal rotation. Almost every single time the shoulder is posteriorly dislocated, it'll be an internal rotation. You get light bulb appearance. Case 2, the normal radioarticular surface on the lateral view is tilted 20 degrees dorsal, 20 degrees volar, 11 degrees dorsal, 11 degrees volar, just to complicate you guys here. All right, so it's 11 degrees volar. Remember that it's going to be tilted volarly. If it's neutral or dorsally tilted, you want to be suspicious that there's a distal radius fracture. Last one, which feature does not lead to a metatarsal fracture? Poor quality films, proximal fracture near the joint, not reading clinical history, mid-shaft fracture location. All right, so there's the fracture, so mid-shaft fracture location. Those are usually much easier to see. All the other ones would cause you, more likely to cause you to miss the fracture. All right, thank you.